Welcome to AETCM, the emergency medicine channel.
Yeah.
A 40-year-old male presented with complaints of bleeding from left nostril since few hours before reaching to ER. On initial 10-second assessment, airway was patent, no gurgling of sounds, no pooling of secretions. Breathing, air entry bilaterally equal, respiratory rate 16 per minute, saturation 100% on room air. Coming to circulation, BP was 124/80 millimeters of mercury, pulse rate 90 per minute, GCS full and pupils bilaterally equal, reacting to light. He was afebrile. Coming to history, no known comorbidities. A 40-year-old male presented with complaints of bleeding from left nostril since few hours before reaching to ER. He was having history of nasal discharge, nasal block and headache since 1 day. And he had history of air travel 1 day back.
Okay.
And also he had history that after a forceful blow, he started this nasal bleed.
Okay.
No history of any other trauma to the face or foreign body. On examination, patient was conscious oriented. There was active bleed from the left nostril. So we told him to keep line tortoise position by bending forward and keeping the pressure over the
Okay.
ala.
Okay.
And then after 10 to 15 minutes, we reassessed the patient.
Okay.
The bleeding was stopped. So then at time we did a local examination. There was only no active bleeding was there. Only few drops of blood was present in the nostril. No hematoma was there.
Okay.
So we also called ENT at that time. They came and examined the nose, and they also had the same thing. Then they discharged the patient with augmentin, and they told the patient to come in to review in OPD. And after 1 week, and after 1 week after augmentin dose, he came after for review. No similar complaints was there in that 1 week. They took an X-ray PNS, and there was having a left sinusitis features. They gave a wash and they conservatively managed.
Okay. So we had a middle-aged man who has come with epistaxis. So it's a classical presentation that you will have in the ED. So what are the key things that you need to keep in your mind from the history point of view when you are having a patient with epistaxis? History things. You are having a patient with epistaxis. 1, 2, 3, 4, 5, 6 points. From the history, what all things you wanted to know?
Any history of trauma. Then any comorbidities of the patient.
Okay.
Whether he is hypertensive or any on drugs.
Okay. What drug to be specific?
Anticoagulants.
All anticoagulants to be specific. Antiplatelets, anticoagulants. Then?
Similar history in the past.
Similar history in the past. Okay.
Then any upper respiratory infection.
Signs of any upper respiratory infection. Reason. Most commonly habit. Nose picking. So that is the most common reason why the patients will come up. Nose picking habits. Then. So again, they can come up with the epistaxis patient is coming with melena. Okay, to you. He is coming with melena. So how you should be approaching this melena, history of melena?
Should ask whether he swallowed the blood.
So if the patient is coming with melena and he is telling that I am having few drops of blood that is coming from my nostril, what will be your impression regarding that?
Mostly posterior.
Mostly a posterior nasal bleed. So that is the next concern. So key things in your history, what you asked is where exactly, what location, what triggered it. So how did this happen? Whether he is on any medication, nose pricking, any recent infections, drug history as you told, and these are the key things that we need to ask in for. And most commonly, you said regarding comorbidity, there is one misguidance with the people that hypertension will cause epistaxis. There is no evidence for that. So the people will think that hypertension is causing epistaxis. It is actually when the patient is having epistaxis due to the pain or anxiety, his blood pressure is going up. So that is a usual thing. And even the consultants, senior consultants in the ENT, they will tell you control the blood pressure, then we will manage the epistaxis. So it is actually hypertension has nothing to do with epistaxis. Hypertension will not cause an epistaxis. So that's the one thing. There is no evidence for as such. Okay. So that is one thing. So when a patient come to the ED, so these are the key things that you may be asking from the history. And our concern is ABCD stabilization. Again, epistaxis being a huge amount of blood, the patient can aspirate, airway compromise. That actually is very, very rare. Maybe traumatic. Yes, maybe on anticoagulation or maybe the worst part, it is nasopharyngeal carcinoma, the patient can bleed. So that's the worst epistaxis that I have seen in the ED is an nasopharyngeal carcinoma patient. 2 patients we had, they came in with epistaxis, post-radiation epistaxis, which is more dangerous because the whole tissue, everything will be fragile, and where to give tamponade, where to apply your cautery is a big question. So that is the role of your sphenopalatine artery ligation, the interventional radiology, all those comes for those group of patients. So routinely our when a patients come to the ED, our concern, examine the patient anterior or posterior. So that is our first concern. So majority of the time it is anterior, as we are all aware, because of the anatomical aspect of the Kisselbach's plexus, the ICA and the external carotid both coming together with your ethmoidal artery, sphenopalatine artery, labial artery all together forming the anterior aspect in the Kisselbach's plexus. So that is the first anatomy. So that's the most common area, and it's always dry. Anterior aspect is always dry. So when you have the climatic condition, maybe in the winter time and all, it will be more and more dry, and chances of epistaxis is more, and also the chance of having an upper respiratory infection is also more during that time, during the winter time. So that's the first examination. The next thing we have to do, as you told, the pressure, that is that you have to do the Trotter's method. So that is a classical thing, pressure. Then going to the next thing, what do you need to do? We need to exactly know where the bleeding is happening from. So you need to ideally irrigate with warm saline is preferred, because warm saline preferred, it will cause some amount of vasoconstriction also. So you irrigate that area and you see where is the active bleeding coming from. Then the role will come for silver nitrate cautery, which we don't usually do in the ED, because abroad and all you will get the silver nitrate cautery. They can just go and do the cauterization, or the routine cautery is easily available that you can do. But while you are doing the cautery, what is the most important thing that you need to keep? Don't cauterize both the sides. Only one side should be done, because there is a chance of perforation. So that is the next thing. So silver nitrate. The next thing is the tamponade. So tamponade, what is the thing that you need to? You have the Mirosil pack, which is the easiest and the best option that is available for you. So you can go ahead and use a good tamponade mechanism, and you can apply that. And before that, you can use the alpha adrenoreceptor blocker like oxymetazoline spray. So you can just give some spray, it will cause peripheral vasoconstriction. So that is the next thing that you can keep in mind. Then the role come, what is the role of tranexamic acid locally? Whether you can apply a local tranexamic acid or not. So that is a question. There are a lot of studies in this aspect, but there are one study which has found to be, it might be effective. There is no harm in giving this. So maybe the tamponade, over the tamponade, maybe a 0.25 ml of Tranexa, you can mix and you can just pour it over the tampon, whichever you are using, and so that it will have some local effect. So you are spraying your oxymetazoline, similarly you can do this also. Then the next comes whether the bleeding doesn't stop. Anterior bleeding doesn't stop. You need to think in terms of a posterior nasal bleeding. So that is again tamponade. What you need to do is the classical Foley's catheter. You need to insert it and with the bulb, and you need to pull down, and that will give you some tamponade effect. But sometimes, like as I said, in nasopharyngeal carcinoma and all, it might not be effective at all. So you need to think of the next step, that is a interventional radiology, and finally surgical option. So that is the mnemonic epistaxis, what I have told you. EPISTAXI. That's an X for tranexamic acid, T for tamponade. So epistaxis is a mnemonic that you can remember. All the things, whatever we have done for this patient, we didn't do any tamponade. So we just local examination and just some local spray was given and he was discharged. And now the question comes whether you need to give antibiotics. The reason for antibiotics for epistaxis in this patient. Which patient you will send off with an antibiotic, which epistaxis needed to be admitted, which epistaxis you can send off from the ED. Antibiotics first.
If we are suspecting any sinusitis, any upper respiratory infection causing the epistaxis,
okay. Okay, we have any evidence of any bacterial infection as such we can give, but not for epistaxis. We have not given antibiotic for epistaxis. For epistaxis, when you wanted to give antibiotic, that is my question. Suppose you are planning that pack is going to be there for more than 48 to 72 hours. Then you need to give an antibiotic. Otherwise, routinely it is not indicated for epistaxis per se. If at all you wanted to give, amoxicillin clavulanic acid is a good combination. Maybe there was an underlying sinusitis as suggested by the X-ray PNS, which was taken later on, but maybe some markers or fever, cough, all those history that you were telling, maybe there was some reason why an antibiotic was started. But routinely for epistaxis, antibiotics is not required. Then the next group whom you need to admit or keep under observation in the ED.
When older age group, we can admit with comorbidities.
Okay, so anyway, it's a simple hemodynamic compromise. So definitely you will admit them. So hemodynamic compromise, you need to admit. The patient is on oral anticoagulation, preferably to admit them. So the next question, the patient is on warfarin and he has come with epistaxis. And his INR is 4.5. What will you do next?
Withhold warfarin.
So what will you do next? The patient is on warfarin. So evening 4 o'clock he had a bleed. She is supposed to take 6 p.m. warfarin. 4.5 is the INR presently, and the patient has come with epistaxis to you. How will you manage this?
Can withhold the dose of warfarin.
Okay, withhold the dose of warfarin. Then I am giving another scenario. INR is 8.
Vitamin K.
Depending on the bleeding.
Depending upon the
Uncontrolled bleeding, we can give FFP and control pictures.
See, when you are seeing bleeding, the bleeding in the sense, it should be in an area which is, you cannot control that bleeding. This bleeding, you can control it. There is an uncontrollable bleeding, intracranial hemorrhage. We cannot do anything. Into the lungs, you cannot do anything. Even GI bleed, technically speaking, we can control by doing an immediate endoscopy. But rest everything, it is not an immediate intervention. You need to give correction irrespective of the INR. But if it is like 4.55, as she said, withheld of the drug is enough. And most importantly, you should go back and see why the patient was on anticoagulant. What is the reason for an anticoagulant? Whether it is for an atrial fibrillation, or whether it is for a valve replacement that has been done, or it is for a chronic pulmonary embolism, or the patient is taking for an embolic stroke. So that reason you should sort it out. So that is the reason why you have to think, okay, why he is starting. And again, irrespective if it is above 8, you can give one shot of vitamin K. But vitamin K only if it is above 8. But rest of the things, FFP and all, we will make sure that if above 8 and with bleeding, yes, you can give. But even if above 5, life-threatening bleeding, which are the bleeding area which we cannot control, we need to give the reversal with FFP. So that risk versus benefit, you need to say patient to patient, you need to see and take the decision. And the other newer anticoagulants, whatever we have already discussed a lot of time, which are all the reversal agent, but that you need to understand. So our concern will be those group of patients, definitely we need to admit. So we need to keep them under observation. And again, as you said, if there are comorbidities, you said comorbidities. So all comorbid patients, you need not admit them unless and until there is a hemodynamic compromise, there is an active bleeding. Posterior nasal bleeding, always preferable to admit them in the hospital, because the tamponade effect of this, you cannot send them with this for this tube and all to at home. But the rest of the patient, if you are observing them for the next 1 to 2 hours, there is no hemodynamic compromise, there is adequate tamponade and there is no active bleeding, you can send them home. Maybe oxymetazoline spray is what only needed, but definitely they will be coming back to the OPD for the removal of tamponade if at all it is there, and they can follow it up further. So the refractory is what we need to admit, and definitely refractory, just not admission, you need to think of sphenoparietal artery ligation. Or your interventional radiology is very prominent these days, so you can just go and embolize those blood vessels directly. So that's in a nutshell. You have anything else that to be add on? You have anything else to be supplement to whatever we have discussed? You can just go ahead and let me know.
There is no only the approach to the bleeding.
Okay.
So if there is active nasal bleeding,
Active nasal bleeding can be little bit louder. So.
active nasal bleeding, look whether look our ABC, airway is secure,
Okay.
Breathing is normal, circulation is normal. If it is no, we have to resuscitate at the time, and then ENT immediate consultation should be done, and should be arrange the OT for the intervention of surgical ligation. If there is if these all are secured, then we can do a conservation management, that initially trotus position, and then oxymetazoline spray we can use. If the bleeding stops, then we can reassess, and after some time we can discharge. If it is not stopping and persisting, we have to know the source, so we have to do a DNA. And if the anterior source is identified, then chemical or electrical cautery we can try. If it is not, again bleeding is persisting, we have to do an anterior nasal packing. And if it is not controlled by that, we have to do bilateral nasal packing. And if the bleeding in any way is the same, bleeding is stopped, we can reassess and then discharge the patient.
Okay.
If it is not
Stopping.
bleeding is persisting, and if the posterior source is seening, we have to, if the anterior bleeding is not stopping with bilateral nasal packing, we have to suspect that it's posterior
Nasal
bleeding.
pack.
So we have to do the posterior nasal packing and then ENT consultation, and we have to admit the patient.
Okay. So only thing what I'll suggest is that when you give a pressure tamponade, don't remove it. So that's the one thing. You document it. This is what you have done. So you are confident enough. You have given a Mirocil pack. Just document that you have given a Mirocil pack. So whoever is the other person should not come and start removing. Whatever be the thrombus, whatever has happened, it will remove, and again the patient will start bleeding. So you need to trust the process. Whoever have done that, and the documentation need to be done properly. Okay, fine. Thank you.